Good evening to everyone who has joined us here today, parents, friends, doctors, colleagues, and one and all. To this retinoblastoma webinar, challenges that we face in 2022 to close the care gap in retinoblastoma, a common childhood eye cancer. Our aim today is to raise awareness regarding the diagnosis of the disease and also to make you aware regarding the different treatment modalities and all the challenges that we face when we come across these patients. I'm extremely thankful to NTOD for organizing this social initiative and awareness during this retinoblastoma awareness week. And special thanks to all my colleagues and team retinoblastoma who's here as speakers for giving their valuable time in this webinar. And very special thanks to Mr. Sherin, who is a parent of one of our patients who will be sharing his experience with us. So today we will be discussing again on the challenges. I'm going to share a few slides right away over here. Yeah. I'm Dr. Fairuz, and I'm an oculo-oncology, oculoplasty, and a retinoblastoma specialist. Going directly to what retinoblastoma is. Retinoblastoma, the global burden of this most common childhood eye cancer, is reported as 8,000 cases per year, and worldwide, including every part of the world. So in India, it is reported that we see around 2,000 cases per year. And also in China, our neighbor, it is the same number of cases that we see per year. Unfortunately, 50% of that burden of 8,000 cases per year is in India and China. And I'm extremely fortunate to be able to associate it with these two countries in treating these retinoblastoma babies. Now, the challenge is, again, regarding the demographic disparity, which Dr. Vasudha will be talking about regarding the number of cases. Also, advanced cases, which is seen in the less developed countries of Asia, Africa, and South America. Now, what is the main challenge that we face even in this era where we are quite aware of various illnesses, diseases? The thing is, retinoblastoma goes unnoticed. Children doesn't complete it. But still, it's not too difficult to identify this disease. The most common symptom that a child presents with is a white reflex, as you exactly see here. So a white reflex is a white spot in front of, in the center of the eye of the child. And sometimes it can be very, very subtle like this, which is very evident when you take a flash photograph in this child. So any child presenting with a white reflex, be the child, presenting to a pediatrician or a family doctor, needs immediate attention of an ophthalmologist to do a detailed evaluation. Squinting of the eye is something, again, which is a very common symptom. And why this squinting happens? This is how the inside of the eye looks like. When a tumor grows into a certain size, it actually leads to loss of vision. It covers the entire central vision area. So what happens is that the child starts looking with the good eye, which is the left eye in this case, and the abnormal eye started deviating. It can deviate inside or outside, and that's how squinting happens. So never take a squint easily. It has to be, again, evaluated for something hiding inside the eye. Enlarged eyeball is seen in cases where the tumor has grown to a larger size, which has caused increase in the eye pressure. And in a child, the eye enlarges like a balloon because of the tumor which is growing inside, and they can present like this. Protrusion of the eyeball in very advanced cases where the tumor, initially, to start with, it will be inside the eye, but gradually it grows to a size where it actually bursts out of the confines of the eyeball, and this is how it presents. Now, what is important about retinoblastoma and what it puzzles most of the clinicians, including ophthalmologists, is that it can present in various ways, but it is rare. It can present something like this, Usually, these are the situations where it presents as a simple inflammation, but it could be a tumor cell which is seen as this white hypopyon in the eye. It can present as bleeding in the eye, in front of the eye, behind the eye. And these are the patients where most of the time get operated thinking that it is bleeding, only bleeding, to drain the blood. And well, that is not advocated or advised in a retinoblastoma to go and do a surgery inside the eye. It can be so large that it can cause a lot of reaction in the eye, as in this case. The reaction can be so severe that the swelling can be over the eyelids, which usually simulates an infection in a child, and they get treated for infection, until finally, when you do a CT scan or an MRI, you find that there is a tumor hiding inside the eye. And finally, even these eyeball can shrink after a lot of reaction happening in the eye, and the child can present like this. So a detailed evaluation is very, very important. Now, a tumor extending outside the eyeball is very, very dangerous. Why is it so? So the eyeball is connected to the brain via the optic nerve. We have a nerve which extends from the eyeball to the brain, as you can see here. So anything which comes out of the eye, there is a high risk of this tumor spreading to the body via the blood vessels and also through the nerve into the brain. And a tumor spreading to the brain is very, very bad for the child, and it's almost impossible to save the life. So to start with, these tumors actually is a very, very small one. So the earlier detection, it is absolutely possible, 100% curable to save the eye, the vision. This is how the inside of the eye looks like. We have the nerve here, which I told is connected to the brain. The center part of the vision, if these two areas are cleared, the vision is going to be 100% perfect. And tiny tumors, very easy to treat, and we save the eye and the life. It can grow bigger, very close to the nerve, but still safer, very, very close to the nerve, a little bit dangerous. Some tumors can grow, keep on growing, and then it covers the entire nerve, and then it grows to a size where it covers the entire eyeball. So this is how it starts with. The earlier we detect it, the better for the child as far as life, the eye, and the vision is concerned. Very rarely we do see this unfortunate situation, but well, in less developing countries like India, as I told you, due to lack of awareness regarding the symptom, and with the parents and physicians, sometimes we see these cases. The child does have a very minimal protrusion of the eye, but you see what is happening behind. It has directly gone through the nerve, and there's a large tumor sitting in the brain. Very, very, very unfortunate to see this. So diagnosis, what are the challenges that we have in 2022 is delay in diagnosis, delay in catching the disease, and then the patient presenting at a very, very late stage. And well, this child had a squint, very evident white reflex, but parents ignored the sign. And there are social beliefs where parents believe that having a squint is a luck for the child, but well, it may not be possible in all cases. Misdiagnosis. So this child presented as an older child, because retinoblastoma is usually seen in younger children, very rare in older child. So she had a history of trauma. There was bleeding in the eye. The treating doctor thought it's just a bleeding inside the eye. A surgery was done for the eye. And finally, a tumor which was inside the eye came out of the eye. So, well, we do have challenges of misdiagnosis also. And then because of all these things, children present with advanced disease. So examination of retinoblastoma from a retinoblastoma specialist perspective and an eye cancer specialist perspective, it is very, very meticulous and thorough evaluation of these children. We just don't take the children into the clinic and just see them, making them sit on the chair. These children are given general anesthesia, they're taken to the operation theater, and we scan the entire eye thoroughly from one corner to the other, throughout 360-degree. And these are the smaller instruments that we use and a bigger equipment that is usually used to document everything. And each and everything about the tumor is documented so that we can stage and group the disease. So this is very, very important, and this is exactly what we do and never compromise on that. So that is regarding the diagnosis and challenges. Going to the treatment, well, the treatment modality that we use currently is chemotherapy in retinoblastoma, as in any other cancer. But well, there are different ways of giving chemotherapy in retinoblastoma. Systemic chemotherapy, where you give injection through the vein, where the drug goes through the body and then into the eye. We get excellent results with it, and this has really changed the phase of management of retinoblastoma. The advances in retinoblastoma that we have seen recently is the intra-arterial chemotherapy, where you don't put it into the vein in the body. The tumor, the drugs, the chemotherapeutic drugs doesn't reach the body of the child, but it's directly injected into a large vessel, which actually supplies blood to the eye. So this is the vessel which supplies blood to the tumor. So the chemotherapeutic agent is directly injected into it, so that there is absolutely no toxicity of the drug in the body. It is also equally effective. But in countries like India and less developed countries, intra-arterial chemotherapy is much, much more expensive, and most of the patients are not able to afford. Like if systemic chemotherapy, 6 cycles, it would take 60,000 to 80,000 to complete the entire course. One session of intra-arterial chemotherapy, the financial burden for a patient would be around 1.5 lakhs, where a minimum of 3 to 4 sessions is required for a complete regression of the tumor. In fact, in advanced disease, intra-arterial chemotherapy is extremely beneficial. Then we have intraocular chemotherapy. We inject drugs into the eye. It could be in front of the eye or even behind the eye. So this is not a primary management. This is an additional management after we either do a systemic chemotherapy or an intra-arterial chemotherapy to shrink the tumor, and whatever is remaining to save and salvage the eyeball, we do this intraocular chemotherapy. Along with that, we have various other modalities as additional treatment, like laser therapy, cryotherapy, and radiotherapy. Next is enucleation. Enucleation is the removal of eyeball in retinoblastoma. There are situations where we have patients presenting with advanced tumor. Even as a practicing, retinoblastoma specialist, it is unfortunate for even us to take that decision. And obviously, it is very, very difficult for a parent that we understand losing an eye for a child. But this decision is taken at a certain point of time where we know that keeping the eyeball might be very risky for the child's life. We want to save the life first, and if possible, the eye and the vision. So most of the time, the parents are worried about the rehabilitation after removing the eyeball. And it's very difficult to counsel them that, it is so big that we have to remove it. But once you promise the parent that, we are going to replace this eyeball with a almost naturally looking eye for you, which is an artificial prosthesis, most of the parents, they come into terms with this bad situation. And of course, as a surgeon, you should be able to deliver this kind of an outcome to the child. So this child had to remove his left eye. It's very, very difficult to even identify which is a normal eye and artificial eye. So this is how the rehabilitation process that we do. We do have customized ocular prosthesis, where the prostheses are fitted. It is measured, fitted, and painted exactly like the normal eye, where it's even very difficult to identify. Anyway, this large tumor, eyeball with a large tumor, doesn't have vision. So if that eyeball, which is completely blind, is risky for the life of the child, well, enucleation is a good option for this particular treatment. But with advancement of the treatment, as a specialist, we always try our best to save the eyes if the life is safe. Now, removing the eyeball, just removing the eyeball is not the end. This is for the doctors and also parents to know. We do, again, examine these eyeball, the nerve, the entire coat of the eye. And this goes to a very good pathologist who actually evaluates the entire section and gives us a report. And Dr. Kaustubh is going to talk about it. So the treatment challenges, again, we do face this: social beliefs, deferred treatment, and even financial constraints. Social beliefs, I'll just take you through one case over here. From a very good financial background, this child was educated parent, bilateral both eyes retinoblastoma, right eye and left eye. And left eye, as you can see here, it's already bulgy, high pressure, and this is how it looks like. Absolutely non-salvageable eye. We will not be able to save that left eye. With difficulty, we were actually able to salvage the right eye, the good eye. In fact, the tumor is well controlled. We, in fact, advised enucleation or removal of the eyeball of the left eye, but the parents were definitely not willing. They took the child, they just disappeared, lost to follow up. They went for traditional medicine treatment, and this is how the child returns. In 8 months, it's quick. The tumor has grown bigger. It has even reached the brain, and we couldn't save this child. So these are the social beliefs and that our society has. And in contrary, this is a child from a very, very, very low socio-economic background who was supported for the treatment. Thanks to Iksha, Mr. Tanmay is here. Well, again, similar kind of a situation, tumor in both eyes, right eye, good, better, and the left eye is completely bulgy, which has to be removed. What you see here is inside of the eye of the right eye. Of course, it's a very large diffuse tumor, but with strict follow-up, with good treatment, all the advanced modern treatment, we could save that right eye for the child. So these are the things. Follow-up is very, very important. And this is how he is. He has vision. When he came down, he was completely blind because left eye was gone. Right eye, large tumor, no vision. But now he has vision in his right eye. And what you see here is the prosthetic eye. The child and the family is fine. Last slide here. Retinoblastoma is a genetic disease, which most of the public parents forget, and most of the doctors, they forget to tell this to their patients. So this is a father who had retinoblastoma, both eyes removed, radiated, the prior treatment which was available. He never knew that his child can have retinoblastoma in the eye. Absolutely no clue. All right. This child had retinoblastoma right at birth, but there was a delay in diagnosing because they were not aware of the fact that it's a genetic disease. And he presented late, and the left eye was quite advanced. Right eye we could save, and this is how he is in 2022. But well, of course, there is a lot of difference from what happened in 1980 in 2022. Even though he had to lose one eye, he has exactly very good vision in the right eye and a good prosthetic eye sitting in the left eye. So the take-home message from my side is white reflex is definitely not right in a child. If you find a white spot, don't take risk. Immediately, you have to seek attention of an ophthalmologist. Retinoblastoma is the most common childhood eye cancer, so beware of it. It is a curable eye cancer. If we catch it early, we treat it, more than 99% curable. We don't want to lose any child. We don't want to lose any eyes or vision in these children. Always avoid misdiagnosis. Do not delay treatment. Any query in the diagnosis from an ophthalmologist or a pediatrician or a physician, please seek a specialist's opinion on this. Never, never shy away from that. Treatment advances definitely has improved the outcome in the recent past. So our effort always as an eye cancer specialist, a pediatric oncologist, a pathologist, a geneticist, everyone is always to save life, eye and vision in these children. And please join us in this effort, and please, please, please spread the strong message. Thank you very much for your patient listening.
Thank you very much, ma'am. That was a wonderful lecture. And I do believe that several parents who are watching, ophthalmologists as well as treating oncologists and ocular oncologists, have a lot to learn from this. You've sent out a very important message to the community out there that we need to look out for that white reflex. It's extremely important and often missed, as the kids are absolutely sometimes it's not possible to notice such a small tumor in such a small eye. So of course it is quite important, and the familial aspect is very important too, because even though some parents know that they have retinoblastoma, they have a sort of denial or a sort of negligence to go on and get their children screened. Thanks a lot, ma'am, for covering
Thank
that.
you, Rolika. So I'll just, since you told about the genetic aspect, there are situations where parents even keep away the fact from the child as they grow that the child had a retinoblastoma or a cancer. You know, they would never say the real fact. They say that you had some problem in the eye, we had to remove it. So even the child growing up doesn't know that he or she ever had a cancer in the eye. So if he or she doesn't know, how is he going to even be aware of the fact that, you know, it is his responsibility or her responsibility to take the child when it's born for an early screening to find out? So these are the certain things that we still face. Yeah.
I absolutely agree. Today itself, I was speaking to one of the parents who was absolutely, happy that the whole treatment phase is over. But they were also pretty solid about that. I do not want to carry this forward ever in my child's life. So thanks for highlighting that point.
Yeah. All right. So can we go to the next speaker, Rolika? Do we have any questions from the audience?
For now, we have one more question for you. And that is that, ma'am, when the treatment modality changes as per the plan, how difficult is it for you to counsel the parents that now we have a different plan in mind? Earlier, we had a different one.
Yeah, so Rolika, what I believe and what I have learned from various institutes that I have worked, it's a very precious learning. Patient care is so very important, right? So basically you have to sit with them. You have to explain to them what exactly where you started. So after every examination of my kids, I sit with the parents, whether it is like a very regular follow-up. I see the same faces every month, but I make it sure I sit with them, explain to them exactly how the journey is going, right? So right from the beginning, if you have totally elaborately discussed the journey with the parents, they're also aware as much as you are as a treating doctor, what the condition is. So it's not difficult to tell them now, you know, we are going to take this step. Now, this is how we are going to take a path. So right from the beginning, so it's not my journey alone. It's a journey together. The parent, the child doesn't know anything. It's just the parent and the treating doctor who are, you know, moving together. So at every step, things have to be informed to them. It's just not coming out and saying like, you know, okay, treatment is over and this is how it is, so we go to the next. Sit with them, explain to them, and that's how, you know, patient care and counseling should be, especially in parents who are going through this bad situation where they have realized that, you know, the child is diagnosed with an eye cancer. Yeah, it's not difficult. Yeah,
absolutely agree with you, ma'am.
Yeah. All right, so it's a pleasure and definitely an honor to have Dr. Sunil here, a good friend and a colleague of mine, part of a retinoblastoma team. He heads the pediatric oncology, hematology, and also the bone marrow transplant team of Majumdar Cancer Center at Narayana Health City, Bangalore. He's extremely well known for establishing BMT in India. Welcome, Dr. Sunil, and I hand over this session to you on how is it challenging for you in, you know, initiating chemotherapy and treatment in these children. Over to you, and once again, welcome, Dr. Sunil.
Good evening, everyone, and thank you, Feroz, for first of all having this session together today. And I remember we, got together last year as well, and it was a great learning for me as well personally. So, but I have to acknowledge today that I think you have covered every aspect of it today, so we can all just now relax and sip a cup of coffee, because I think all the important aspects of the challenges which are there in retinoblastoma care have been touched upon by you. However, I will just through a case presentation also kind of try to put across what are the challenges we see in initiation of the treatment. That's what the topic was given to me. I know it's a mixed audience, and we have some of the doctors as well as some of the parents who are logged in. So it's going to be a little mixture of some basic information as well as some of the take-home messages for both the physicians as well as to the parents. I think you mentioned this a little bit. I'm just putting it here again, that retinoblastoma, although it is a localized eye cancer, but it can spread out of the eye and can spread to various parts of the body. It can spread through the nerves into the brain and spinal fluid. It can spread through the extension of direct extension, what's called as choroid extension into the eye socket, which is outside the eye globe of the eye. And it can also spread through blood and lymphatics to the other parts of the body, and bone marrow and lymph nodes are the common areas which can spread to. And I think you highlighted that how important it is to know the spread of the retinoblastoma, because the treatment is so much dependent on that. This is one of the classifications which most of the parents must have come through, and you just showed some pictures on this. And that is when the retinoblastoma is intraocular, that means it's limited to the eye, globe of the eye. And in that case, treatments are so much effective that you can practically cure each and every one of them if they're adequately treated. And we also, based on how big the tumors are, how well the vision is preserved, and how far they are from the nerve in the retina, we kind of group them from A to E being the worst or the most advanced, and group A being the smallest tumor away from the seen part of the eye, and other groups based on the examination. This is what I think you showed, and when you do an examination, an ophthalmologist on examination, they will help us to classify and group these into different groups based on how the size of the tumor they see, and also how far it's from the seen part of the eye. But when it comes out of the eye, as I said earlier, we can stage it when it's out of the eye, and depending on where the extension has been, whether it's gone into the orbit, it has gone to the lymph node, it has gone into the brain, it has gone into the other parts of the body like the bone marrow, then we stage it as per that. And it's important to know this, because the treatment and the planning of the treatment will depend based on this. Now, the treatment, as was highlighted earlier, it's a multidisciplinary team effort, and it is an ophthalmologist, a pediatric oncologist, and sometimes a radiation oncologist, and last but not the least, our psycho-counselors, our genetic specialists, and other people who are involved in the care of these patients. Now, this is a very important, slide here, and that tells us what are the goals of the treatment? What do you want to achieve with the treatment? And I think the most important thing which you want to achieve with the treatment, of course, is to save patient's life. That is the foremost important goal in the treatment, and that we have to kind of reminding ourselves as well as to the patients and their families again and again that the saving the life is the most important thing. However, once the first goal is achieved, we want to save vision as much as possible. Saving vision means we want to save the eye vision first of all, and of course later on the eye as well if it's possible. And we also want to reduce the late side effects or other problems which can occur later on in these particular patients. So this is very important, because I think that is the principles which govern the treatment of retinoblastoma. And I think this was also showed by Dr. Feroz, and that's how we treat them. The treatment would be either surgical, that is enucleation or removal of the eye, which happens, and sometimes it has to be done, and local therapies or local treatments, which the ophthalmologists give directly to the tumors to kind of burn the tumor. And then we are involved with the chemotherapies. That means you can have systemic chemotherapy, which is given through IV. It can give directly into the eye, called intraarterial. It can be given directly into the eye, called intravitreal. And sometimes radiation would be required as well as a part of the treatment. And we don't want the details of that, but then we do require these treatments either alone or in combination most of the times to deliver the optimum treatment and optimum cure. The role of chemotherapy in retinoblastoma was very studied many decades ago. It has been shown for the last almost 70 years that how important chemotherapy is there, and it's used basically in two settings. That means first, it is used to, if a surgery is required, for example, we need to reduce the tumor size and do a surgery later on. That would be one mechanism or one way the chemotherapy is required. Also, it's required sometimes when we want to save the eye and we don't want, the operation is not required, but eye removal is not required, and we want to give them chemotherapy along with the focal therapy. That's another indication for chemotherapy. And also it's sometimes given if a surgery has been done, eye has been removed, but on the removal of the eye, there has been seen that the tumor is not limited to the eye globe. It has come out of the eye globe, and then we need to give chemotherapy so that the tumor doesn't recur later on, even after the surgery of the eye or the removal of the eye has been done. There are various drugs which are used for chemotherapy used for retinoblastoma. The most common chemotherapy which we use is called as VEC, or vincristine etoposide and carboplatin. And this is how it is given. It's basically given every 3 to 4 week cycles. And on an average, we give around 6 cycles most of the times to most of the patients every month for them to have the adequate chemotherapy regimen. When the tumor goes out of the eye, when it's out of the globe, then of course we need to add further treatments. We need to give chemotherapy, of course, but we also need sometimes radiation to be given if the tumor has gone out of the eye. And it's not a good thing, because as Feroz mentioned, if it's within the eye, we can almost save 99% of the patients. When it goes out of the eye or the globe of the eye, it becomes a bad disease. And depending on how much spread has happened, the chances of cure definitely come down. And when it spreads to other parts of the body, like brain, or it goes to the bone marrow, then the cure rates are very, very dismal. And we hardly see any patients getting cured if the tumor has spread to either to the bone marrow or to the brain. So I find it very interesting tumor in that way. If retinoblastoma is linked to the eye, almost all can be cured. But as soon as it comes out of the eye, either to locally into the orbit, or it goes elsewhere in the brain or in the bone marrow, then the cure rates dramatically drop down, and some of the times we not even may be able to cure them at whatever treatment we give them. So that is just some background of what treatments are required basically in a case of in a case of retinoblastoma. Now, what are the challenges which we find in this treatment is where we're going to be discussing. I'm just putting this case presentation, which is basically a 5-year-old who presented in 2017 with a white triplex, which was just mentioned by Feroz earlier on evaluation on MRI and examination, which ophthalmologist did. We found that this child did not have any spread of the tumor outside the globe, but it was a little advanced in the globe, and we kind of grouped it as what is called as group D retinoblastoma. Now, what was decided that we probably can save the eye of this child, and in an attempt to do that, this child would require basically chemotherapy, which the oncologist will give, and also repeated examinations and focal therapies in form of cryotherapy and laser from an ophthalmologist. So that was a treatment plan which was decided for this child in an attempt to save, of course, the life, which is our primary goal, and also secondary goal here was to also save the eye and the vision. However, the challenge which we face was that first challenge which we face is that most of the families, when they hear the word chemotherapy, they are not very keen to have that, and this family also was very apprehensive and didn't want to have the chemotherapy. Now, most of this apprehension or the fear with chemotherapy comes from the adult experience. We see our older people, our elders, our family friends who have been suffering from malignancies, cancers, and they get chemotherapies, and we see kind of the bad effects of chemotherapy on them. And we also see that most of them, it can control the cancer but cannot cure them. That's all comes to the adult experience. But I want to say here that chemotherapy in retinoblastoma is probably the mildest chemotherapy which is ever used on any type of cancer. It is very mild. It is 2 days of treatment every 4 weeks. And most of the time, this treatment is delivered and they go back to their homes, come back after 4 months, get another 2 days of chemotherapy and go back. The side effects of the chemotherapy are absolutely, I would say, minimal. However, every treatment comes with some side effects. They're minimal, and they are at no way at par with some other chemotherapies which are given for other cancers, and also not like the chemotherapies which is given for the adults, for example, for various cancers. So with some of the children, especially the children who are younger, less than 3 years, and even infants who are less than 1 year of age, the parents have an additional apprehension of how the smaller infants are going to deal with chemotherapy. So I want to tell everyone here that, younger the kid is, better they deal with the chemotherapy, the better they, tolerate the chemotherapy. Children have the amazing capacity of recovering from the effects of the chemotherapy. And as I said, the doses and the frequency is so mild that it really doesn't lead to much short-term and long-term side effects. However, we do need to keep a little bit of infection prevention practices when they're getting the chemotherapy. hygienic precautions and and seek attention if there's any infection which comes in the patient. Long term, not much in the long term side effect range. So hence, after all this counseling, this family did agree to go ahead with the chemotherapy. They understood that it's important for us to do this for saving the child's life, and also we may be able to save the child's vision and eye. So they agreed to continue to start the chemotherapy. We gave the patient 6 cycles of chemotherapy along with the local treatment and intraocular chemotherapy, which was given by an ophthalmologist, and his lesions did completely resolve. This is his a post-treatment where the tumor had resolved, and we kind of put him on a follow-up so that we follow this child for recurrence. Unfortunately, after almost 1.5 years, this child comes back again with a recurrence of the tumor, and this recurrence of the tumor was seen on examination with ophthalmologist, which was done on a regular basis. Now, what we recommended for the family this time, because there was a recurrence, was that we still attempting to save the child's eye, because we still feel that the recurrence was small and it was away from the same part of the eye. So we did advise them the chemotherapy, and also what was advised, because even after chemotherapy and some local treatment, it was persistent. So we advised them that they should undergo radiotherapy in addition, so that this tumor can be killed forever. So there's another challenge now we see in the treatment of retinoblastoma at the initiation and sometimes during the course of the disease is apprehension with radiotherapy. Now, radiotherapy, as we all know, is kind of considered bad, and of course, radiotherapy does come with some side effects which are long-lasting, especially in children. But I have to say here, the brachytherapy, which is the localized radiotherapy, which is like we call it plaque brachytherapy, that a small plaque is put on the patient's eye, wherein the radiation is given just locally to the tumor with no effect of that elsewhere in the body. And this is probably one of the safest way of delivering radiotherapy to anyone. So the first myth which is there with the radiotherapy is that the brachytherapy, which is a very localized radiotherapy, wouldn't lead to any long-term or short-term side effects at all. However, it's technically challenging, and we need to a few centers doing it. So that's a logistic challenge, but I wouldn't say that from the side effect profile point of view, that should be much to worry about. However, when we give radiotherapy as axial beam, which is a traditional radiotherapy, it does come with some side effects in the long term. However, saying that the proportion of patients who require that kind of radiotherapy is very, very less. But even if it's required, especially if the tumor has gone out of the eye into the orbit, it would be required and it should be given, because that is what we required in that circumstance to save the life of the child. Of course, we don't have the option of saving the vision there and the eye there, but it should be given to saving the life of the child. So that is another one which we encounter. So this child did undergo brachytherapy, but there was a recurrence of the tumor again, and there was some vitreous seeds as well. So now we have given a fair attempt of saving the eye for this child. Even after the second recurrence, the eye is still salvageable. That eye we can still cure this child. We have given enough opportunity for ourselves and to the child for saving the vision and the eye. But even after that, there has been a recurrence, and now the recommendation from the ophthalmologist that we should do enucleation, and that is the most challenging bit, I would say. And it was highlighted by Dr. Feroz also in the treatment of retinoblastoma. The most challenging thing is to counsel or explain the family why enucleation is advised. Enucleation, as was explained, is the removal of the eye. And I think it's one of the dreadest things the parents and the families want to hear from the doctor, that the eye needs to be removed. But as was explained, in advanced retinoblastomas, where we know that leaving the eye behind is going to be life-threatening, and we already showed before and explained before that when this tumor comes out of the eye, goes in the orbit or goes in the brain, then it becomes sometimes incurable. We can't even do anything, and the patient doesn't lose only the eye but also the life. So I think enucleation is sometimes required in especially advanced disease locally. Let us listen and follow what the ophthalmologist, an ocular ophthalmologist is telling us. And it is something which should be done in those circumstances. And it was also shown by Feroz that the rehabilitation post enucleation disease is fantastic. You have got very good processes as close to the natural eye. However, this patient didn't agree for enucleation, and that, as I said, it's very unfortunate, and we do come across it occasionally in our practice. And this child was lost to follow-up. They stopped receiving our calls, they stopped responding to us, and they stopped reporting to us. However, this child comes back after a few months of abandonment of the treatment. And if you could see here now, it's very unfortunate that the tumor has filled the whole eye. There has been extension of this tumor into the optic nerve and into the brain. And when we looked at his bone marrow and the CSF, that is the brain fluid, they both were involved with the retinoblastoma. Now, unfortunately, this tumor has spread out of it's not extended out of the eyeball in the orbit, has also extended through nerves into the brain and also through the bloodstream into the bone marrow. And unfortunately, now there's no treatment possible now. So it's quite sad quite, I would say, also demotivating that this child was on treatment for a few years. There was a very dedicated and sincere attempt to, of course, save his life and his eye. But at a certain stage, it was not possible to save his eye, and enucleation was advised. And because of the stigma associated with enucleation, which is mostly social and cultural, which was not undertaken, and that choice was made at that point of time, and that led to this massive recurrence. And unfortunately, this child, because of this extensive disease, couldn't make it and succumbed to this very curable disease, which could have been probably cured. Now, that was on the medical aspect, the challenges we find, but on social and aspects, the challenges are of funding and treatment costs. Although retinoblastoma treatment, when it compared to other cancers in children and for that matter, any other cancers, it's not a very expensive disease to treat. The treatment can be finished, in few thousand rupees per cycle. Having said that, there's still a concern, and some of the families who come from socially and economically challenged backgrounds may not be able to do that. And here comes the role of various NGOs and various support organizations, and especially ICSHA has been doing a great job here. And we haven't had this problem too much in the last few years since ICSHA has been doing, supporting the children, but that's definitely a concern in various parts of the country. And that's another challenge which we face when we initiate the treatment for the children. And of course, abandonment of the treatment, either at the beginning or in middle of the treatment is a very important concern, especially in Indian settings. And there are various reasons for that. Some are medical and some are non-medical. And this is something, the most important thing I feel is that because nothing is visible outside, it's all limited to the eye. And sometimes, the families and the patients do not understand the gravity of this disease, and hence leads to delays in the treatment, abandonment, and sometimes that we have to, the cost you pay for that is huge. So these are some of the challenges I wanted to highlight through this case presentation in initiation of the treatment. And of course, we have other challenges and other aspects as well, which will be discussed a little later. But that is what I wanted to put forth here. So thank you very much for attention, and I would request if any questions, and we can take them. Thank you.
Thank you very much, Dr. Sunil, for covering every aspect of challenges in treatment. So as you rightly said, most of the parents are worried whenever you say the term chemotherapy. They kind of worry about the short-term side effects. And the most important thing that they ask is, what is the long-term side effect of chemotherapy? As a pediatric oncologist, how would you deal with this?
So as I mentioned, of course, every treatment, whether it is for malignancies or cancers or even for non-malignant conditions, there would be some side effects expected of the treatment. And the most common three drugs used here, vincristine, etoposide, and carboplatin, are of course chemotherapy drugs, and they one of the most important side effects which can be expected is infection risk, especially in the short term. So we definitely have to counsel them on, taking hygienic precautions, what to eat, and having seeing a physician if there's an infection or a fever. So that would be a short-term thing, which is the most common thing. Second, there will be some drug-related side effects, like vincristine can lead to constipation, but it's not that huge a concern. We do guide them and report to us if that is the case. In the longer term, the drug called carboplatin can have a little bit effect on the hearing as well as on the kidney functions, but the doses which are used are very small, and the cumulative, that means that cumulative, the total dose which you give is also very less as compared to some other cancers where the doses are quite big. So we don't see that concern very often. However, we still screen them every visit for the kidney functions and also hearing on assessments every 2 to 3 cycles, so that if there's any indication, then we will either change the treatment or modify the dosages. So yes, there are some of these concerns which may be there, but I would say, one in comparison to the chemotherapies used for some other conditions, both in children and adults, they're minuscule. And number 2 is that we can't forget that we are treating a cancer, and that cancer is life-threatening and is going to take the life of the child. And also, of course, if we not treated adequately. So I think in that context, probably the cost we pay to the chemotherapy is very negligible.
And Dr. Sunil, what is the maximum number of cycle that you can give in retinoblastoma?
So as you mentioned, I think 4 to 6 cycles would be our average kind of treatment which we can administer to them. But I think at that case I showed you that this child received a little more because there was a recurrence of the tumor and we still wanted to save the eye second time as well. So we can go up to more cycles of treatment. We have given patients 12 cycles of treatment as well if they required it. So that is something which can be given for the standard. What is the standard treatment which is given? We can go to 12 cycles also, safely, of course. And there are some patients who, especially the spread has happened outside the eyeball, especially if they're in the orbit, in the localized to the eye, its socket, or even sometimes gone in the lymph nodes and all, which are still can be cured. Those cases, we can in fact change the chemotherapies and give a little bit more stronger chemotherapies as compared to this, and those also can be delivered safely. And that is done with a view to cure those tumors which have spread out of the eye, and they're bad if they're not dealt properly. So to answer your question, the standard ones we can give up to 12 cycles also sometimes if required.
Thank you, Dr. Sunil. Dr. Rolika, do we have any questions for Dr. Sunil from the audience?
Yes, ma'am. There is a question that how do you like to follow up your patients through the cycle of chemotherapy, and what investigations should the patient go through, and also after they return back for the next cycle?
So as I said, the VEC, which is the most commonly used chemotherapy regimen for retinoblastomas, they are quite, I would say, safe as well as quite gentle chemotherapy cycles. So only for the first cycle, we want to see how they behave or how they respond to this. So we usually want to see them back in 7 to 10 days time and see them once in the outpatients again, just to make sure that they haven't experienced any side effects. We may sometimes also check their blood counts. They have not drawn the blood counts too much. That is something which we do mostly in the first cycle. If they're not from they're not locals, they go back to their own cities. We do ask them to do that locally, see a local physician, or also contact us on a video call or something so that we can keep a check on that. But having said that, if most of the times after the first cycle, we really do not need to do anything. They get chemotherapy and come back after 1 month, see ophthalmologist, get a local examination and local therapy done, and come after that for the chemotherapy. And we really don't see them for the next 4 weeks in between at all. Yes, as I said, when we start you have given 1 cycle chemotherapy and then we order another cycle in 4 weeks time. As I said, carboplatin can be a little harsh to the kidney, so we would check always a creatinine or a kidney function test before we give the next cycle. And we'll also make sure that the blood counts, which can be reduced a little bit by the chemotherapy. They are normal before start the second chemotherapy. So when they come next time after 4 weeks, we would check their CBCs or the blood counts and the creatinine so that they're in normal range before we start the next cycle of chemotherapy. That's how we follow them in the, while they are on chemotherapy. And this is what the test was required.
So there's a question from one of the parents, and that is that if at all my child is not responding to the VEC regimen or the current chemotherapy protocol regimen, then what parallel options are there, or are there other drugs available?
Yeah, so retinoblastomas respond well to chemotherapy, and the VEC regimen, which has been being used for so many years now, so many decades now, has shown to be the best even after so many decades of the treatment of retinoblastoma. Now, if the tumors are not responding to chemotherapy, that is VEC, then we hardly use an alternative chemotherapy regimen. I think then we have to decide very seriously whether we need to give an alternative treatment like radiotherapy, which I showed, like a plaque radiotherapy, or sometimes we can choose to do an intra-arterial chemotherapy so that we reach directly into the eye, or we give ocular chemotherapy. If the tumor is in the part of the eye where the blood supply is not very good, we can directly give chemotherapy there. So these are other options of giving directed chemotherapy or using an alternative treatment like a plaque brachytherapy. But having said that, if these modalities are not effective to the extent we want them to be, then we go to the basic goals and principles, and that is we need to save the life of the child. And we may have to then decide of doing an enucleation rather than attempting multiple lines of chemotherapy or alternative treatments and risking the child's life and, of course, the eye. Thank you.
Absolutely, Dr. Sunil. I'm sure we all agree, even Dr. Rolika agrees with it. Yeah, very rightly said. Yes, so can we go to the next speaker?
Sure.
Thank you.
Again, a pleasure and honor to have Dr. Vasudha here. She is a pediatric oncologist and heads the pediatric oncology department at Rainbow Children's Hospital. And her experience with pediatric oncology is extensive. It's not only in India. So she had worked in UK, London. So she exactly knows when she, derouted from UK, London and came to India. I'm sure she has seen a vast difference in how, the parents take it, how the treatment is, and etc., etc. So she's going to tell us how the demographic disparity happens, be it in presentation or, how the treatment of retinoblastoma goes on. And welcome, Dr. Vasudha, over to you.
Thank you very much, Dr. Feroze, for this opportunity to participate in this great session on retinoblastoma awareness. So yes, I think when Dr. Feroze gave me this topic, I thought that it will be actually quite, quite obvious and quite easy. But then as I went on looking at the data, I was also quite pleasantly surprised. So I'll be talking about demography and disparity in retinoblastoma. And I think like our previous speakers, Dr. Feroze and Dr. Sunil Bhatt have said, it's the most common malignant intraocular tumor found in children. And what is important to understand that if it is untreated, it is fatal uniformly. 80 to 90% of these children affected by retinoblastoma live in low and middle income countries. But what is the unfortunate thing is that although the higher proportion of children live in low and middle income countries, the outcomes for these children in these countries is not that great. In fact, in areas like Philippine Islands and Nigeria, the mortality rates can approach up to 90 to 100%, and the survival rates are quite low in low income countries. While the West, the developed countries are moving more and more towards globes and vision salvage and quality of life, like Dr. Sunil Bhatt mentioned in his previous cases, unfortunately, we are still having to deal with saving life first in retinoblastoma, although a localized disease is actually even 100% curable. So in my talk, I will just take you through these 4 important questions. Does demography and disparity matter in the treatment of retinoblastoma? How significant is this disparity? What are the factors responsible for this disparity? And with the theme of our retinoblastoma awareness, how can we overcome this challenge? So the disparities in several countries are similar. They are ethnic, socio-economic, definitely more so in the low and middle income countries and low income countries, and the demographic variability. So this is a fantastic paper by the global retinoblastoma team, which was published in the JAMA Oncology just very recently, where they studied a huge number of children. In excess of 4,000 children were studied with newly diagnosed retinoblastoma. And what they actually showed was quite phenomenal. Although we knew that low and middle income countries are underrepresented, the burden of disease is high, they're presented in more advanced diseases, they actually showed us data that almost 50% of children from low and middle income countries had extraocular tumor at the time of diagnosis. So as we saw with the previous presentations, an intraocular tumor has much, much better outcomes. It is curable in a majority of children, and even vision salvage and eye salvage is a possibility. But in low and middle income countries, almost half of the population presented with an extraocular tumor, compared to, mind you, only 1.5% of patients from high income countries. So this is a very, very significant disparity that very, very stark, and shows that the kind of difference in treatment outcomes in these children, and even in the presentation of the disease per se. So when they studied the global burden of retinoblastoma, again, like I mentioned in my previous slide, almost about 70 to 75% were from low and middle income countries, and a bare 15.3% were from high income countries. And we do know from Dr. Sunil Bhatt's talk that survival and the chance of saving vision and also the long-term outcome actually depends upon the severity of disease at presentation. So obviously a disease that is localized has much, much higher chances of cure as compared to a disease that has already spread. And unfortunately, a metastatic neuroblastoma has very, very poor outcomes. But what the study found, that at the time of diagnosis, 99% children from high-income countries had an intraocular tumor, whereas 25% from those from low and middle-income countries had an extraocular disease, and some of them even had a metastatic disease. So if you look at this graph, you can see that more than 50% of those children who had an extraocular disease were from low and middle-income countries, and a mere 1.5% were from high income countries. So right at the presentation, we have got a big disparity in terms of, and this presentation is going to actually impact the treatment as well as the long-term outcome for that particular child. They also saw that if you see the stage 3 and stage 4 diseases were more in the low and middle income. On the right hand side are the percentages. So you can see 62%, 50% were more in the low and middle income countries as compared to the higher income countries, where the stage 3 and 4 disease are at a mere 0.7 and 1%. This is another study from the Lancet journal, which is a very reputed journal, where again they go on to show the mortality with retinoblastoma. And just to draw to your attention, two absolutely contrasting figures. So if you can see the mortality in Kenya, it is about 73%. That means only a very, very tiny number, 25% of children are actually surviving with this disease. And whereas in Canada, the mortality is only about 1%. Further, again, the presentation of the disease with spread outside the globe is with presentation with proptosis or swelling of the eye outside is 85 to 55 to 85% in the low income countries, whereas it is 0% in Canada. So this just represents the effectiveness of their screening strategies, that they're able to pick up retinoblastoma much, much earlier when it is at an intraocular level, and hence their outcomes are also much, much better. But this is something that really surprised me when I was reviewing this subject, is we kind of tend to assume that, of course, because of socio-economic factors, because of several cultural beliefs, because of the ethnicity, because of the distance, so on and so forth, it is kind of understood that there is a lot of disparity between low and middle income countries and the high income ones. But are these disparities limited to the low and middle income countries? This highlights the significance of this disparity because it is not limited to the low and middle income countries. This is a study from the US where they studied the ethnic, racial, and socio-economic disparities only with regard to retinoblastoma. So it's a huge study covering about 10 years, and they studied 18 SEER registries. So SEER registries are registries that actually register the number of cancers every year, what are the types of cancers, what is the age group, and so on and so forth. So when they studied this, they very strangely noticed that Hispanic children, that is those of Spanish descent or the Latino descent, had a higher percentage of extraocular disease. So it is quite significant, 33% versus 20% in non-Hispanic or American children. And also the percentage of extraocular disease was higher in the counties or in the areas that were having a lower socioeconomic status. Again, a lower educational attainment was associated with a higher incidence of extraocular disease. Higher crowding inside a house was associated with extraocular disease. Higher level of unemployment was associated with extraocular disease. And again, more importantly, higher rates of enucleation were associated with a lower educational attainment. So this just goes on to tell us how important it is to actually talk about retinoblastoma and educate the public. Because mind you, this is a study in the US, where the facilities or the access to care is not a problem. But in spite of that, the first problem is the recognition of the disease, where many of us are stumbling. The same thing was seen in the UK, because these findings were quite surprising. And the UK also did a similar study where they studied about 189 children. And they saw that 81% actually presented with advanced retinoblastoma, that is group D and group E, and almost 70% required enucleation. Although it was not significant, what they saw is that a South Asian ethnicity who were in the most deprived financial range were associated with a higher likelihood of advanced disease. Again, presentation is so important in all these studies, that they go on to tell us that educating the masses is so important regarding the early signs of retinoblastoma. What about back home? So this is a great paper by Dr. Usha et al., where they've studied a 16-year review of how children presented and what were their outcomes. And here, I would like to draw your attention to, when we talk about why is there disparity, what are the factors responsible, just look at this study that shows that the delay in presentation from the onset, so from the time the parent has noticed, whether it could be a leukocoria, that is a white eye reflex, or a swelling in the eye, or a redness, whatever was the symptom, it was about 8.3 months, okay, and the range was 0 to 84 months. So they actually had a child who was not diagnosed for more than 3 years. Yeah, so that is a significant delay. And importantly, abandonment and refusal of treatment is a big problem in our setup. In this study, also 25% patients refused any kind of treatment at presentation because the primary reason was enucleation was recommended and they completely refused. And unfortunately, this is another problem that we deal with, where the disparity of treatment is highlighted, where almost 45% defaulted during the course of therapy. That means they just started the therapy and just left it midway. And very important to all those parents who are listening also, it's very important to continue your therapy once it started, because look at this, once of all those who had defaulted therapy, almost 5% presented with really advanced disease. And like Dr. Ferooz's patient, unfortunately, many a times nothing can be done for these children. So why are we having so much disparity? The disparity stems from poor socioeconomic condition and, more importantly, lack of awareness and education. Like my previous speakers have highlighted, actually retinoblastoma is not an expensive disease to treat. And if detected early, chemotherapy, few cycles, and EUA with the ophthalmologist is all they need, with probably some local therapy. So poor socioeconomic conditions should not be a barrier for us to treat this disease. But lack of awareness and education, yes. So this starts right from delay in diagnosis, delay in presentation to the doctor, understanding why enucleation is important, understanding why so many cycles of chemotherapy are important. So that is a major obstacle for all of us treating these children with retinoblastoma. So the two main themes that have emerged in all case studies, not only in India, but worldwide, is that this disparity results finally from delay in diagnosis and access to care, cancer-directed care. So even if a child is diagnosed, for them to reach the right place of treatment takes a long time. So we did discuss these factors, ethnic, racial, and socioeconomic or cultural in our setup. But as we were actually fighting with all these factors, unfortunately, there's another big problem that hit us that actually highlighted the importance of the demography and the disparity with that is the COVID pandemic, where access to care was completely hampered. And this is a paper from, actually two of the authors are on this panel. So the impact of COVID-19 lockdown on retinoblastoma treatment. And this paper, I have put it just to highlight that if you can see the, in terms of need for active treatment, the third point, 96% of them were semi-urgent. So retinoblastoma, whenever we look at treatment, it can be urgent, non-urgent, or semi-urgent, and a majority of them require treatment on a semi-urgent basis. But look at the delay that they faced. 63% patients return to follow-up after a mean of 45 weeks. Okay, that's quite a significant delay. And more importantly, 60% of the eyes had worsened and progressed in their stage. Interestingly, this paper also shows us the demographic details. And if I can draw your attention to the table on the right-hand side, the patients who are traveling from a 500 to 1,000 kilometer majority in the study. So this kind of highlights how much our patients have to, work hard to actually reach the right center for care. And that's about this. So what is the other side of the coin? What is the nice side, or what are we not able to see from this side? In high-income countries, retinoblastoma is a curable disease, and their attention has now shifted to eye salvage, vision salvage, and improving the quality of life. So how has that been possible? Creation of specialized referral centers, multidisciplinary units where you have got the ocular oncologist, pediatric oncologist, the histopathologist, and everyone sitting together and looking at these cases, arriving at the right treatment, decoding of the genetic basis of the disease, formation of screening programs, very, very important, because in all our studies, we have seen that delay in diagnosis is a big obstacle, and introduction of chemotherapy, not just systemic, but intraarterial and intraocular as well. So how can these challenges be overcome? Education is a very, very, very important component in addressing delay in diagnosis, as well as treatment refusal, which is a big problem in our kind of setup. In addition, awareness programs to address the psychosocial and religious stigma associated with enucleation, especially. Twinning, telemedicine programs have taken off very, very well in low-income countries. Because these programs can not just provide financial support, training and education, organizational help, but it can open a dialogue between the low-income country and the high-income country to discuss, to hold multidisciplinary team meetings to understand what is the best way forward for that particular child. So this includes campaigns, to understand about retinoblastoma education program. The first example was in Honduras way back in 2007, when they linked the retinoblastoma awareness campaign with the national vaccination program. And to their surprise, they found that the reduction of extraocular disease just from educating the parents was reduced from 73% to 35% post-campaign. So that's a fantastic reduction. And this is again a very recent paper where how telemedicine and centralized care has actually changed the history of retinoblastoma. This is a study from Jordan in a hospital called King Hussein Cancer Center, where the mortality rate when they started this twinning program in 2003 was 38%. And over the course of 10 years, it dropped to 5%, mind you. And the eye salvage rate increased from 4% to 61%. So that's a fantastic progress in that. And what this not only improves the patient outcome, but it enables a knowledge transfer between professionals. So much so that after 10 years, the cases that were discussed were less than 3%. So you're equipping the other people, also the other professionals, to understand the disease and make their own decisions. And the treatment changes based on consultations also decrease from 70% to 7%. That's like equipping that country to actually educate another country to do the same. So with us, we have got great centers and great doctors. So this can be done with metropolitan cities to tier 2, tier 3 cities, twinning with those cities, and trying to help most of these patients who come from a lower socioeconomic strata, and trying to reduce this disparity as much as possible. With that, I will end my talk. Thank you so much.
Thank you so much, Dr. Vasudha. You have covered entire thing, extensively with data and stuff. And I know we have learned a lot from your presentation at this point of time. So Dr. Vasudha, do you agree to the fact that there is absolutely no disparity in the treatment offered when you compare West to, country like India and other,
not anymore. Of course, now we have got intraarterial chemotherapy, we have got genetic screening, so intraocular, intravitreal chemotherapy. So with that, we are no way, anywhere lesser than the West. But the problem is for patients to access this kind of thing. And like you rightly pointed out, intraarterial and intravitreal chemotherapy tend to be a little heavy on the pocket for the patient. So that kind of whatever gap is there needs to be addressed.
And obviously the awareness regarding the disease. There is a huge disparity, when you compare the West and our country, yes. And do you have a message to the pediatricians, Dr. Vasudha, because you are a pediatrician, like how they can contribute? Because most often these babies, for a vaccination visit, for a well baby clinic, the first physician that they actually encounter and go and land up in the lab is a pediatrician. So what is one message that you would want to, give to the pediatrician as far as a baby and, whole body examination is concerned?
So the one thing about retinoblastoma is that it is very easy to screen. Just shine the torch. That's the only message I'll give all my fellow colleagues here, because unfortunately for other childhood cancers, we have no way of screening and catching them early. But retinoblastoma is giving us that chance. So right from the newborn period, during your consults with the well baby clinic, at least up to the age of 2 years, and definitely if possible up to the age of 5 years, please shine a torch in the eye, because leukocoria is the most common presentation of retinoblastoma. And if that's caught early, then most of the time the child does well and it can be saved from the complications.
Yeah. So yes, I think that is a very, very strong message that we want to convey here, and coming from a pediatrician is much more valuable, right? Even a squint for that matter, if you suspect a squint, and always most of the time the parents go and complain, like, we see that so if at all the parent is doubtful about it and even you are doubtful about it, I think it definitely demands further evaluation with an eye doctor. Yeah.
So an acquired squint is always a very important red flag. It's just not only for, definitely for retinoblastoma, but again, it definitely needs evaluation as to what is the cause of the squint. And the most important thing to understand is that children do get cancers. A lot of pediatricians find it very hard to digest that they don't have it in their differential. So please keep it as a differential. And like I said, screening is possible for retinoblastoma. Ask for history of any radiation to the eye, or any kind of genetic history as well in the parents. That also enables early screening for the child.
Yeah, thank you so much, Dr. Vasudha, for putting that across. Rolika, any question for Dr. Vasudha?
Yes, ma'am. Thank you so much, Dr. Vasudha, for covering the pediatrician aspect. And you have covered that one very important question that a parent had asked was about how to screen, like at what stage should they be screening. Like, for example, we have retinopathy of prematurity that can be screened at an early stage, and there are causative risk factors for it. But unfortunately, retinoblastoma does not have that. And what do you usually follow for screening? like in your practice?
So we advise the pediatricians to have a look at the, like I said, shine a flashlight in the eye of the baby right from the newborn period. And the baby is going to come back to you every 6 weeks to 3 months for a vaccination or for a well baby clinic. Do see that. But importantly, one message I'd like to give parents, hopefully that they can propagate to other people, is now everyone's got a smartphone, right? So all you need to do is click a picture of the child with the flash on, and you will see that your child has got red reflex in both eyes. And if that is not there, I think that is a very easy way to catch the white eye reflex in children.
Yes. Thank you so much, ma'am. There is a question on the social portal for Dr. Sunil, sir. However, Dr. Feroz, would you like to take the question? And that is that they need to know if the tumor will be lost on its own after all the treatment, or will it come back after a few years? I believe that's a parent who would like to know your opinion on that.
Yeah, so Dr. Sunil is not here. I'm going to take this question, and I think it suits as an eye doctor for me to answer that question. Yes, there is a chance that tumor can come back, and that is exactly the reason why, especially during the course of chemotherapy, the chances are very less. And this is exactly what I tell all my my parents. The tumor, once you stop the chemotherapy, the risk of tumor coming back is higher in the first 2 years. But then, well, of course, there is risk of tumor coming back at any point of time in their life. And that is exactly why we do a long-term follow-up for these patients. Follow-up in the sense the patient is followed up until life, And initially, the follow-ups will be much more frequent. It will be a 6-monthly follow-up. Once we are sure that it's kind of stable, there is a definite yearly follow-up for these children throughout their life, throughout their adulthood. And so it's very, very important. And yes, there is a chance that tumors can grow back. Yeah.
Right, ma'am. There's another question for you, that can topotecan and methylene be used together for the vitreous seeds?
Yes, we do use it together for vitreous seeds, especially when it's, I start with a very less, toxic drug, which is topotecan initially. But if I find that it's not completely going away with topotecan, definitely there is an addition of a more stronger medication, that is melphalan, along with it. And we can combine both in the same sitting. Both the injections can be injected together. Yes.
Thank you, ma'am. Thank you for answering the question.
All right. So do we go to the next speaker of the day?
Yes, ma'am.
Yes. So, well, it is a pleasure to have Rolika with us here. You had seen her speaking, and Dr. Vasudha has also shown a wonderful publication that she had recently on, the follow-up of these patients and how they were lost to follow up during the COVID time. So I think she is the best person to tell us how follow-up is so important in these children and what are the challenges related to that. Over to you, Rolika, and thank you so much for being here.
Sure, ma'am. Thank you so much. I'll just share my screen. Is my screen visible?
Yes, and you're audible.
All right. So this is a very important presentation that I'll be giving, and it's on three important letters in our lives, and that is LFU. Rather, I would say the three very scary letters, because unfortunately they stand for loss to follow up. And that's an evil in our lives, and we dread it dearly. But we also make sure that we land up loving to follow up. So LFU for us does not stand for loss to follow up anymore, because we follow very stringent protocols for the same. And I'll be talking on follow up and tracking obstacles that we have faced. So why the loss to follow up occurs in the first place? Like, why do we have such a situation? It happens because of lack of education. So that's what we're talking about here, that people are not aware of retinoblastoma as a possibility, as an ocular cancer possibility. And therefore, the retinoblastoma awareness comes into play. People have lost hope and faith while they're undergoing treatment, while they get tired. Parents often get tired and are absolutely left, that helpless. That is the word they use. Family denial, of course. There are parents who have become lost to follow-up after we have recommended enucleation because they're denying to remove the eye. Social taboos, of course, we have families coming in wherein they follow that they believe strongly, social taboos and religious beliefs, that they believe that it is because of the higher forces that are leading to the issues with their child. And of course, they have future concerns. They're worried about the child's future, education, and life forward, including marriage for the female children. And the monetary aspects. Unfortunately, this happens in all the social stratas. It happens to the higher class families as well as middle class and lower class. And the lower class families, unfortunately, are unable to seek treatment because of monetary aspects. And of course, distance from center. Unfortunately, all over India, there are very few centers treating retinoblastoma, and sometimes the patients are unable to locate a center or reach a center. So I'll be talking on why to follow up, when to follow up, and how to follow up. Coming to why to follow up. So let's take back the initial aspect of why the loss to follow up occurred and convert it to why we should follow up. We need to educate and warn. We need to educate the society, the people and about retinoblastoma. We need to develop a trust and hope. We need to convert loss of faith. We need to have the family support. We need to build it. And we need to reason the social taboos. It's not difficult. It's not easy for the parents to believe that their social taboos are long lost. And we need to seek God's blessings instead of believing that it is because of a superior power. We need to trust the child's abilities. Do not doubt the future of the child because your child is stronger than you think your child is. The monetary aspects can be covered by providing funding. We have several non-governmental organizations working for that, and I'll be covering them too. Distance from the center can also be shortened. And we also need to counsel the parents that distance is more important than treatment. So the treatment will obviously be covered once the distance is taken care of. When to follow up? Well, in unilateral RB, we have a regimen that we follow, and that is we keep the active cases on a 4-weekly protocol. And slowly, when the child starts responding, and I call it promoting, that is when we move on to 6 to 8 weekly cycles of evaluation. And that goes on for 6 months till the child is completely regressed. Slowly, we move on to 3 monthly follow-ups for a complete 1 year and 4 monthly for 1 year, followed by 6 monthly till the age of 10 years. Some centers follow as 6 years also. However, one thing to be remembered is that it doesn't end. It is a lifelong evaluation that should be done, and yearly follow-up is mandatory. In bilateral retinoblastoma, the same is followed, except for that we follow the child 4 monthly for 12 months and 6 monthly till the age of 16 years. And when do we assess the patients, and when are we okay with handing over the patients from the specialty to locally by ophthalmologists? In unilateral RB, we can do that when the child is disease-free for 12 months. This is because certain parents cannot travel all the way. And bilateral RB, we prefer to do it after 2 years of complete regression. Sibling screening is also absolutely mandatory. And I'm glad that the genetic aspect has taken over and we are able to analyze the genetic aspect way before even the child is born. And therefore, we can counsel the parents regarding the sibling screening too. Loss to follow-up has been a challenge for all of us, and we have learned how to fight it off, and I'll be showing you how. And that is the achievement that we have come to, how to follow up. So, well, COVID times have been absolutely trying for us, and we have learned that first thing we need to do is understand the current practices, have a patient-centric advice, and troubleshoot on your follow-up. These are the 3 aspects that we need to understand while following up. And this is a paper that we have. It has been a very difficult paper, rather, not an easy one, because we have seen what difficulties we faced. And while going through the counseling and while going through the whole process of managing and following up the patients, these are the aspects that we considered for following up. And I'll be telling them one by one. Here is how we document and maintain the records, and we have a default form. And here we analyze day by day. We do not leave the children. We do not leave the parents. We constantly call them up. We have a very strong team wherein the fellows call or the counselors call, and we make sure that we trace them till the patient comes back or is given a scheduled proper appointment. Real-time tracking of national and international updates is mandatory. Several protocols rather have been drafted over the COVID trying times, and one of them has been by Feroz ma'am herself, and that have been absolutely helpful. And we need to do also the risk analysis of children when they're on active treatment. It is important to know that which child is on active treatment and how often they need to be followed up. It was very difficult for us to send them to local ophthalmologists because they couldn't travel, they couldn't proceed further, and we have lost approximately 8 to 11 children along the way. A high-level communication with parents is important, and understanding the reason for loss to follow-up and providing optimal solutions is mandatory. We need to provide psychological support and reasoning with the parents, and rescheduling the cases as per triage protocols. We need to issue travel letters. We had to take care of it. We had to write emails, postcards also, and make sure that they come back. We had to have regular meetings online regarding handling the situation. Automatically, it was helpful. And we could refer to local ophthalmologists as we have told before. And we had to keep coordinating with them. We had to track that how is the child doing now and how soon can we get the child back to us. We need to provide the pictures to the patient, to the treating doctor, and we had to make sure that the chemotherapy protocols are also conveyed to them. After the child was planned to come back, we had to do optimal COVID-19 testing, strict assessment of the cases, and ensuring the safety of everybody in the hospital. The most important part was the tailored, individualized treatment protocols. It was absolutely mandatory and difficult as well. And the most important part here was actually a generous contribution from several non-governmental organizations. I must say that without them, we could have really not helped a lot of patients that were seeking monetary aspect. And regular counseling of constant defaulters is mandatory. We need to remind them. We need to understand that they are going to again become defaulters. We need to sit with them and take care of what they are thinking and what are the social aspects that they are facing. Awareness campaigns regarding need for regular follow-up in retinoblastoma have helped, just like this one. And 2020 turned out to be a happy 2021 and 2022, just because we could get the children back. This is a team which has meticulously followed up on the patients in our setup, and they've made sure that several patients come back with their hard work day in and day out. They have sat and called up the patients, and here we are. We are happy to see that the patients have come back to us successfully, and we're happy to acknowledge their bravery for us. And he is the guardian angel who is the mastermind behind all of this for us. He's taught us that we always need to not just consider it as loss to follow. We absolutely love to follow up, and we make sure our patients come back. So to conclude, a regular and well-designed follow-up protocol is mandatory, and patient counseling and psychosocial support is all we need. Thank you.
Thank you very much, Dr. Rolika, for putting out your experience, extensive experience. And, I know it's not easy. It's been very difficult time for all of us as, cancer specialists during the COVID times, the burden and, sometimes helpless that we are not able to reach the patient, but well, all is well. A little bit of extra effort probably, always gives us a positive outcome. And thank you very much for sharing, your thoughts on it. Do we have any question for Dr. Rolika, Dr. Vasudha?
Hi, Dr. Feroz, sorry.
Yeah.
Can you hear me?
I can hear you, yes.
Sorry, I just gone to the washroom. I just missed that.
Okay. No, do you have any question for Rolika regarding follow-ups?
Yes, there was a question, ma'am, by Shehnaz, that how was the situation during the lockdown handled? Like, since suppose the patient was willing to come back and get the treatment done, but due to lockdown, they couldn't approach. How could the doctor help there? I think, Shehnaz, you have also been a part of it, so thank you for that too. And it has been a very difficult time, of course, because when the children come back, they are beyond our imagination, because the tumor, which was happily regressed before they were seen last, has now suddenly popped up, and sometimes we consider it beyond our control. And also, as we have seen in our paper, that it was 63% patients that we could follow up after 45 weeks of follow-up loss. We have actually covered to 98% till date after 1 year. So the struggles faced were absolutely combated by the team Dr. Santosh Navasar has created.
Yeah, and one more thing that I would really want to be grateful and thankful is some government has really helped in my practice. I had patients who had to come from Kerala, where there is absolutely no entry in Karnataka from Kerala, but collaborating with government, they had provided ambulance for these children. So it's a government ambulance which was taking the children across the borders. So in certain ways, I'm very grateful for even government official being extremely helpful for taking these babies across and, with the seamless treatment strategies. Well, inside Karnataka, I did have issues where, trains were not available from the poor socio-economic group. But then, yes, we have been constantly trying to push them and, telling them, providing vehicles and bringing them in. There were NGOs who were trying to help. But yes, there was some amount of percentage of loss to follow up due to that and increase in the disease severity. Yeah, it is sad. I hope we never face it. We have studied a lot from this pandemic so that, certain things doesn't get repeated and, the scare. So it's just not COVID. There are many other diseases which also exist, even if there is an infectious pandemic that is happening. So that should never override any other disease, especially cancer, which is life-threatening. And I think we all learned it. I think even the public should learn the fact that COVID is just not the disease which is existing. There are many other diseases. There is tuberculosis. There are so many other diseases where we should be giving attention to. Nothing should supersede or override any other disease in future. It's a lesson. All right.
For you and Dr. Rolika, actually, and now that with the COVID, everything has become teleconsults and video consults. Of course, it's not possible for EUAs for children with retinoblastoma. How has that changed your practice? I mean, for both of you all.
Well, as you rightly said, Dr. Vasudha, teleconsultation is not really advised because we have to really see the eyes. And then, but if it is a center who have a very good retina specialist, if not an ocular oncologist who can really screen the eye, that we are confident and who's with whom we can directly communicate. We have the satisfaction that someone has really seen the eye and there is a very flawless communication between us, then it is possible to kind of transfer the patient to a local place. If there is a RetCam imaging available, it will be nice. It is much more, confirmatory. So they take the pictures, send us, and then a treatment decision is taken together. So facilities are important, and follow-ups, of course, yes.
Yes, I do agree, ma'am. And we did have a patient that I recall that during the COVID pandemic, we tried to have a proper telecommunication, and we had the patient go to an ophthalmologist to be seen, and the retinal examination was done. But unfortunately, in that child, it was a very peripheral tumor. And it was confirmed to us that the tumor is fine and it's going well, but the child came back with a huge peripheral tumor and it was difficult for us to salvage the eye. So because they did not have the facility of examination under anesthesia and indenting and looking out for the tumor. So we did face these problems and they still persist with or without COVID.
Yeah. All right. So we go on to the next speaker of the day. We have Dr. Kaustubh Mule. He is a very renowned and popular ocular oncology pathologist who specializes in eye cancer in his pathology practice. And he has been, the go-to pathologist for most of the ocular oncologists in India, and he heads the National Reporting Center for Ocular Oncology Pathology in Hyderabad at Center for Sight. Kaustubh and me, we go a long way for the past 12 years. And so his way of analyzing any ocular cancer, not only retinoblastoma, has been so thorough and well up to date. So, he's one person that I'm extremely, comfortable and trust for his diagnosis in any cancers. And retinoblastoma is so very important that way because, the enucleation, if we feel that is the end of treatment, it is not. An eyeball which has been taken out requires a very, very thorough pathological evaluation. And that is exactly what Dr. Kaustubh is going to highlight today. Over to you, Dr. Kaustubh. Kaustubh, you're muted. Kaustubh, you're muted. Yeah.
Okay.
Okay.
Okay. Feroz, you actually stole my words. I was about to begin my presentation with the way we first met and the long association that we have had.
Yes.
So, we met, when she was a fellow and I was probably a budding ophthalmic pathologist. I probably didn't know head and tail of ophthalmology. So, Feroz has evolved, faster than how the treatment of retinoblastoma has evolved. She's a world-known figure now. So, it has been emphasized enough how common retinoblastoma is and how easily curable it is, probably if it is diagnosed early and the treatment is initiated quickly. As you all know, retinoblastoma is the commonest pediatric intraocular tumor. Now, you would probably wonder, so I am, just give me a second.
So you can click on the screen once and it will. Yes.
Okay. Yeah. Thank you, Rolika. Okay. So I'm basically a pathologist. And you would probably wonder why someone who deals with blood and urine, doing associated with retinoblastoma. Well, like Feroz said, enucleation is not the end of treatment, but it's rather the beginning of management. Now, over a period of time, over the past few decades, the treatment of retinoblastoma has evolved. Earlier, enucleation was the treatment of choice, but now you have radiotherapy, chemotherapy, and intra-arterial, intravenous, blah blah blah, and it has helped salvage eyes, because of which the eyeballs that I get to see as a pathologist have drastically reduced since I started seeing eyes way back in 2013, and we barely get to see enucleated specimens now because doctors like you all, you're so good at salvaging eyes. Not just eyes, you salvage vision, you salvage life. So the number of enucleations have come down. But despite that, enucleations are still performed. And they are performed in conditions where the tumor is a high-grade tumor or you're not able to see the tumor. And when the eye is removed or the enucleation is performed, this is what an eyeball looks like. This is how it is sent to me. Now you might wonder, why is, okay, before that, in interiors of India, or rather you can say the developing nations, there is a practice that, if the tissue is removed out of the body, it can go into garbage. You can throw it in the dustbin. Can you? No, definitely not. Why? We have seen that whenever there are group D or group E eyes, that means when the tumor is at a higher stage, then it is associated with something called as high risk factors. Now, what are high risk factors? High risk factors are certain microscopic findings, which I see it under the microscope, which when present are associated with greater recurrence of the tumor, or there is a chance that the tumor might spread either locally or it might spread to distant organs, such as it might go to it might go to bone marrow, it might go to the brain, and then they might even be associated with a fatal outcome. Hence, it is very important that the surgeon, and here in the case ophthalmologist, sends the eyeball to a pathologist for a thorough assessment. Now, I'm not going to get into the very details of the eye, but this is what an eye looks like. So, this portion that you see over here, that's the retina where the tumor comes from. And from here, it can go anywhere in any direction and spread outside the eye. Now, the high risk factors that I was speaking about, what are they? Now, when I cut the eyeball which I showed you, this is how a retinoblastoma looks like from inside. So the high risk factors are involvement of the anterior chamber. Then you have massive choroidal invasion. That means the tumor goes from the retina outwards into the choroid. It can go into the optic nerve. It can go into the sclera, or sometimes it can go even beyond the sclera into the extraocular tissue. So these are about 6 high risk factors that a pathologist and an ophthalmologist should be aware of to check in their reports. And these, when present, such kids need additional treatment. Now, when I say that, this is something that needs to be assessed by a pathologist, what are the challenges that a pathologist faces when he's inspecting such eyes? The first and the foremost important challenge is receipt of the eyeball. Now, it is observed that, either the eyeballs are sent in small containers, they are kind of stuffed into a small container and sent. So is that the right way? No. Whenever you send an eyeball to a pathologist, it is important that you send it in a big enough container which has the right preservative. Now, the right preservative over here is 10% buffered formalin. And how much should be the preservative? It should be at least 10 times the size of the eyeball. So you can imagine, probably you would need, say, about 100-200 ml of formalin. Now, this has to be accompanied by a well-filled request form or a clinical history. Clinical history means you should probably mention the age of the patient, then you should mention what treatment has been given and what are the clinical findings. This helps us to study additional tissues. Now, inside the lab, a well-trained pathologist is not available in a lot of places in India. In fact, if you ask me, there are, barely countable well-trained ophthalmic pathologists in India. So it may not be possible for every ophthalmologist to send it to these pathologists. Now, in those cases, it is important that the pathologist and the ophthalmologist both ensure that the eyeball is properly sampled. It is not like you just cut the eyeball, take some part of it and study it. No, there is a protocol for studying the eyeball and it should be studied in entirety. The entire eyeball has to be processed and observed under microscope. Now, why? Let's look at one case. Now, this was a child, 3-year-old child. And if you look at the picture, which is on the top left, you can see there's a choroid over there. There's a sclera. There's absolutely no tumor. Now, this section was from the central callet or the middle portion of the eyeball. Whereas the picture on the bottom right, it shows the tumor going into the choroid. And this was from the periphery of the eye. So had the pathologist taken only the central portion and not studied the peripheral portion, this would have been missed. The child would have probably not received additional therapy and he would have either come back with a recurrence or a metastasis somewhere. So it is important. Now, when an ophthalmologist gets a report from a pathologist, this is what he or she should look for. Once, the presence and the type of tumor, then the location, whether in which part of the eye the tumor is located, whether it's unifocal or multifocal, then the differentiation. Differentiation matters because there are reports that poor differentiation is associated with a poor prognosis. Then, like I said, the presence or absence of high risk factors is very important. And then, like, Dr. Feroz has said, the staging, there's a universal protocol that has followed for staging. And if the high risk factors are present, then this ophthalmologist will go ahead and do a bone marrow or a CSF assessment. which is again also very important. So what to take from this is that always send your specimen or the enucleated eye to the right pathologist, get it assessed rightly, read through the report, and then treat the child accordingly. Thank you.
Thank you, Dr. Kaustubh, as usual, so crisp with all the details, which is essential on all the slides. And I'm sure the message has gone very, very rightly out there that enucleation is definitely not the end of treatment, but, evaluation of a globe and further treatment has to be taken forward. Thank you so very much, Kaustubh, and for your immense contribution in the field of ocular oncology pathology in India. Yes. Rolika, do we have any questions?
Ma'am, there's just one question for sir, that when he notices the risk factors, how does he classify them into histopathological risk factors? How are they classified as minor and major?
Okay, so there are certain risk factors which are classified as major. Among them, one is full thickness choroidal invasion, or choroidal invasion in multiple or single foci that aggregate to more than or equal to 3 millimeter in size, in any dimension rather. Then you have invasion of the optic nerve beyond the lamina cribrosa. The third thing is invasion of the sclera. The fourth is extraocular tumor spread. Then you have involvement of the anterior chamber. So if you see anything among these is classified as major high-risk factors. Now, anything that is involving the choroid, but which is less than full thickness, or there are multiple foci or a single focus which is less than 3 millimeters, is classified as a minor focus.
Right, so.
Yeah. Dr. Kaustubh, I have a question. When you mentioned about the anterior segment invasion, is there a change in the idea of, that being, I know that it's controversial,
yes,
because nowadays even we treat eyes with anterior segment seeding, right? We inject into the intracameral and we try to salvage the eyes. If we are really desperate to save the eye, So do we have to consider that as a major risk factor still?
The protocols don't say that you consider it as a major high risk factor. Neither does the TNM staging mention it. Yeah. But yes, I think if you ask me, it is a local spread. Mm-hmm. The tumor has gone beyond the retina. Mm-hmm. So I think it should still be considered as a high risk factor. All
right. Thank you, Dr. Kaustubh. Thanks a lot.
Hi, sorry. I had a question for Dr. Kaustubh. This is Tanmaya here.
Yeah, hi, Tanmaya.
Hi. So, Doctor, you mentioned that, when the eye is enucleated, more often than not, the tissue is not sent for sampling. Is that something that should be as part of the protocol that's not followed, or is it just something that's just not included as part of the retinoblastoma treatment in India? So
no, it is a part of the treatment. It is, and it is a very important part of the treatment. So every eye that is removed, whether it is a primary enucleation, that means before the treatment, or whether it is a secondary enucleation, that means the enucleation is performed after giving part of the treatment in form of radiotherapy or chemotherapy, it should be sent to a pathologist for assessment.
Okay.
It is a universal protocol.
Okay. So, and it is sent, normally it happens.
Yes.
Okay.
Except in the interiors, where the pathologist is not available, or probably awareness among the treating doctors is not enough. Mm-hmm. That's when, it ends up in the dustbin and the child suffers.
Right. Okay.
One more thing that I would like to highlight here regarding your question, Tanmaya. Most of the time, the eyeball, especially when you're suspecting a tumor, it reaches a pathologist. But sometimes in certain places, it's just a report which goes to the patient or the doctor, telling that the diagnosis is retinoblastoma. Well, that's not what we are looking for, from a pathologist. Well, we know clinically, retinoblastoma is a clinical diagnosis. We know that clinically, and that's not what the confirmation we want. As a treating ocular oncologist, the confirmation that we want is there any high-risk features? What do you mean by high-risk feature is these are the features where there is a high risk for the tumor to spread to the body, where the child can have metastasis because of this extensive tumor in the eyeball. So every doctor in whichever corner of India or whichever corner of the world, they have to ask the pathologist, persistent with the pathologist, that I want the high risk features plus or minus. And that is exactly what I want to know, because that actually helps us decide what is the next management for this child to save the life and also to prevent the tumor coming back into the enucleated socket, which is very, 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 very difficult to treat. Yeah, we can lose life. Yeah. All right. So, well, next we have Mr. Tanmaya here. And I would say the work that ICSHA does under the leadership, Tanmaya is the founder and the secretary of ICSHA, a foundation which takes care of these retinoblastoma kids entirely. And I have been associated with them. And to be very honest, I have to confess here today, 97% of my patients are from a very low socioeconomic background. And you know how I have been able to manage them? We don't tell no to any of these patients who come. No patients goes back without any treatment. And the help that I have got from ICSHA is enormous, where they have been there, going to the patient, talking to the patient. And there are situations where it's not just about the treatment, they just finish it. ICSHA has even funded children for their education and future. So this is an amazing foundation which has helped all these children live a good life, improve the quality of life. And Tanmay, ICSHA Foundation and the team, I think you really deserves, a huge applause in being with these families and kids all throughout. Thank you so very much. And it's a great honor to have you here today. Over to you.
Thank you, Dr. Fairuz. And I mean, it's we wish we didn't have to do what we do, but it's unfortunate that it is what it is, and we're happy to be helpful in any way that we can. We actually crossed a milestone recently, and it was a kind of a mixed feeling for us when we crossed that milestone. But I'll probably come to that in a bit. So I won't take much time. It's late, and it's Saturday evening, so I'll try to be as brief as possible. So ICSHA Foundation, like Dr. Fairuz said, and it's wonderful that we get to work with doctors like Dr. Fairuz, Dr. Sunil Bhatt, and of course the wonderful doctors at CFS led by Dr. Santosh Nawat. So it's fantastic, support from them for the children. So we support the children with retinoblastoma. And we provide the support for the families in terms of the treatment, the financial assistance, as well as the what is the further post treatment as well, because we believe that after the treatment, it's not just about the treatment; it's also about having a sustainable life, right? So we want to make sure that no child loses the sight or anything, the life especially, to make sure that there isn't anything that, we try to pull out all stops to make sure that the child is nothing happens to it. So I think, we started like 10 years into 2010. It's been 12 years since we started. And like I said, providing financial support to look at awareness about the children, to ensure quality of the treatment, and of course a sustainable life is what we're always looking for. So this is a milestone that we crossed. We've been, it's 203 children that we've supported since in 12 years. It's a milestone that we really wish we did not cross, because that means there are that many children who have had retinoblastoma and have survived. Some few haven't. But that's just a huge number that's out there, and we know, and we are quite cognizant that we've not been able to support every child for whatever reason, but it's something that we want to try to make sure that there is no child who's not treated for lack of funds, right? I mean, that's just not done in today's world, and we just want to make sure that no child is goes back because of lack of funding, and we're trying to do that. So we work with hospitals, Narayana Nethralaya, Prabha Clinic, Horus Speciality, Mazumdar in Bangalore, and Hyderabad with Center for Sight, and in Pune with HV Desai. So just come straight to this. I think all the doctors have covered it fantastically, and of course from a medical point of view and everything. We also have seen patients who are coming in, because of delayed treatment or delayed diagnosis, right? And we of course the root cause is definitely awareness, and we are constantly doing awareness campaigns. We did a what we find is that people are coming from the hinterland. So we added a campaign of having articles written in vernacular newspapers, so that it actually reaches out more people in different parts of the country. So it's not just in English newspapers or mainstream in urban areas, but we didn't cover any of those. We went really, towards tier 2, tier 3 cities, kind of a thing, right? I think the second one has been covered quite extensively about the social aspect of the treatment, which especially when it concerns enucleation, and which results in the abandonment of the treatment, which is something huge concern for us. And I think in some of the statistics and information that are shared by a few of the doctors, one thing that's missing is we see, this is our own experience and what we have, is that there is a higher rate of abandonment or a potential abandonment when it's a girl child, right? So we are actually kind of on our toes as soon as we know that it's a girl child, and that especially when it needs any enucleation. So we are actually constantly in touch with with the parents of the child, and whoever else, relatives, and our program coordinators do a fantastic job in talking to them, and they love to follow up. As the thing is, it's we also don't like the fact that children are lost to follow up, so we try to follow up as much as possible. And we also want to improve the quality of medical care that these children are getting. Of course, supporting things like arterial chemotherapy, which is a lot more expensive, which means that for us, it all comes down to money, how much we're able to afford, and how we're able to raise the funds for these children. And that is something that we're constantly aware of. And now IAC is kind of getting to more mainstream. So hopefully the cost of the treatment will reduce in the next few years, as it's more, as there'll be more specialists, and also the equipment and the and everything that's needed for the treatment, the costs actually reduce much more. So that's something that is what we see the challenges right now. We did have a whole bunch of challenges last year, last 2 years with with the pandemic and things getting locked down. Starting with we actually had to speak to multiple police, different states to get a child from Belgaum to CFS for treatment. Many of the children could not travel. We try to reroute children. Okay, you don't have to come all the way to Hyderabad or Bangalore. You're closer to Pune, so go for this cycle of treatment. You can go to Pune to get the treatment done. So there was a lot of rejig that was done. Which is thanks to all your support, we were able to do it for children whose parents still wanted to come for the treatment. And that is the biggest thing, right? Their motivation to continue the treatment. It still needs to be there, and that's something that we constantly push for, to make sure that there is no loss of child because parents just gave up for whatever reason, right? We've never been able to understand that in some cases, but in some cases we do, because they could be because for them, since many of them are daily wage workers who actually will have a loss of livelihood when they leave their work and bring the child for treatment, which can be 4 or 5 days, including the travel and everything. So we actually provide for their stay, food, and some sort of some little expenses for the daily expenses when they're here. We just try to remove the financial hurdle in multiple aspects. Treatment, of course, is already taken care of, and in addition, this travel and stay also we kind of try to deal with it. Some parents who are here who need to be either in Bangalore or Hyderabad, they end up taking up jobs in that city so that they can stay in the city itself for a longer period of time, maybe a year or two, so that they can complete the full treatment cycle for their child, which is really good because that's a huge sacrifice the parents are making, moving, their entire household. So uh, it is something that we always try to reduce the like I said, for lack of a better word, the reasons or excuses parents normally give why they don't want to come back for treatment. And also the other thing that we've seen is when there is a second child that comes along and the second child is fine and normal, the first child is kind of they pretty much let go. So it's reality. So we try to step in and we help a child move into a hostel few years back, so that the child is taken care of because the parents could not take care of the child. So it's something that we just have to be on for that. So I mean, it's fantastic. I mean, thanks to Dr. Fairuz for organizing this, and it's wonderful to have here from all of you. And as much as I think I always know, being here, but it's like I have 2 pages of notes here from hearing all of you. So there is a lot of things that we need to go back and do post this webinar, and it's always fantastic to be here with you. Thank you, and I'll stop now. Any questions, I can take that.
Hi, Tanmya. Thank you so very much. I do have a question for you. I'm sure it's not easy for an organization like ICSHA to raise funds. So how difficult has it been, your journey from the beginning to now?
It's been tough, but I guess it's also been the fact that we have kept our fundraising fairly simple, and we it was about our first circle of friends and families who actually trusted us with their money, because they knew that they knew us one-to-one, right? And that's how it started, right? And now that degree of separation to our donor is actually gone to 6 to 7 degrees of separation. So I actually don't know who the donor is, because there was a time when all of us, all the trustees who run ICSHA, we actually knew each donor, literally, we know all the person. But now it's gone beyond that, so which is great. But then there's still a connect. I can still manage to connect them back to one of us to say that, okay, this person has donated, this is how we know. So it's that network which actually, even today, close to 60% of our funding that we raise is actually from an individual donor. And in India, it's the most difficult thing to raise funds for something like this, because if there's anything religious, if I had a temple, I would have had a queue of people who would actually come and donate. That's the easiest thing to do. And they wouldn't ask any questions, right? But a person who's probably donating like 1,000 rupees has 100 questions to ask us about making sure that we're not running away with the money. So we do, we do convince them. We talk to every donor who has any questions. It's not like we don't ask them how much you're giving and then decide to talk to them. We talk to anybody and everybody, whoever has any questions. The last 2 years has been especially difficult because almost, I think, in 2 years, 100% of our corporate donors dropped off because all their CSR funding went to COVID.
COVID,
right? Yeah. So it was a nightmare, but the thing is, our individual donors really stepped in at that time, because we reached out to all of them again and we told them, listen, we really need your help right now, and everybody came through. Okay. Right? It was just amazing. And although they did do their supporting the COVID initiatives as well, but they knew that this is something they needed to do as also. right? So they did that. I mean, that is amazing. So this year again, we see CSR funding. We're talking to a few corporates there, back on sort of getting back to their other initiatives. So which is nice to see. Good that COVID is over, and even in terms of funding as well. People are refocusing their funding into areas that they were doing before COVID. So that's good. So yes, we should be able to support more children this year as well. So.
Yeah, so COVID has affected in every front, like, yeah, I know. And Tanmay, I think the international, because we have had this discussion before, there are international, NRIs basically who would want to contribute. But I think you have a difficulty in taking funds from NRI in India, right? Yeah.
So we don't have our FCRA, so we can't take any foreign funding.
Okay.
So it's only resident Indians, citizen who can donate to us.
Okay. All right. Yeah. Thank you so much, Tanmay.
Thank you, Dr.
I'm sure there is lots of prayers from all these parents and kids, who have grown up to be super smart with all your help and effort. Thanks to the team. Thank you very much.
Thanks, Dr. Faris.
Yeah. So, yes. So I would like to invite our next speaker, Mr. Sharan Ashok, who's here with us. And, I just open out my entire heart to him coming out here and, being with us today to talk about us being a parent. So Sharan is a teacher who's in Punjab, and he had gone through ordeal, also going through the COVID situation. And I would really want, request Dr. Sharan to, Mr. Sharan to share your challenges as a parent. I'm sure it has been a roller coaster ride for you. So welcome once again, and thank you so very much from the entire team for having you here. Over to you, Mr. Sharan. Mr. Sharan?
Hello.
Yeah, hi.
Yes, ma'am. Yeah, good evening, all of you. I'm really honored to give me an opportunity to speak about some of my experience related with particular disease. So, about retinoblastoma for the very first time. And, my nephew, Danny, who was diagnosed with this disease, he was just 3 months old that time. So initially, it was very difficult for us to identify what was happening with the baby. But somehow, we just realized something was wrong with his eyes, okay? He was not giving a proper, maintaining an eye contact. And moreover, he was just rolling his eye always, okay? So finally, we consulted with a doctor, a pediatrician, who suggested that it can be a kind of nerve problem. So he referred us to a neurologist, and who just suggested us it is not related with that. Better you consult with a doctor, like an eye specialist. So finally, we went to an eye specialist, and where they did some scanning and just informed us he was suffering from there was a tumor on both of his eyes, okay. And he suggested us to to Chennai for advanced treatment. So we moved there, and from where what we came to know that one of his eyes, it was in a very critical condition, and it had to be removed. And from being the family, it was very difficult for us to say yes for a kind of surgery, because always we had some hope to save that eye. So, but anyway, it was operated, and they continued they suggested the treatment of chemo. For the next 6 months, we continued with the chemotherapy. And the very first thing, when they suggested chemo, it was quite difficult for us, what it would be, because we all know that we have seen many times the people who are undergoing the chemotherapy, what kind of changes can be happening to their body. So we were really scared of these whole thing, but it was a kind of mild type of chemo, as the doctor was talking earlier. So after the 6 chemos, there was a significant improvement in his vision of the another eye, actually, which was undergoing treatment. So and later they informed us just visit us every month for the treatment. treatment, and the baby is perfectly all right. There is no any growth of tumor, and it was already like, it shrunk up to certain extent also. So we came to Kerala by the time actually. And at that time, unfortunately, the lockdown was declared with a lot of traveling restrictions. So that was something which just pushed us a little back from going to Chennai and continuing the treatment. So finally, we consulted with the doctor in Chennai who suggested one of his friends who was practicing in our city, Calicut. So we went there, and the doctor did certain checkups and informed us the baby is still fine. He's not having any problem. And, maybe, I don't know, I'm not blaming him, but he was the one who suggested us, just come after 6 months. Just come after 6 months, and even there will be no point of going to Chennai for the rest of treatment because he is all right. And suddenly we agreed because it was something that we all wanted to hear always. Okay. So we were happy, and those 6 months were the really happy time of the life, we can say, because during the time the baby started walking, he started seeing the things, he started picking up everything from everywhere. So we were really happy. But after the 6 months, we went to the same hospital, and they just kind of scanning, and they informed us the condition of this baby is really critical because there was a significant growth in the tumor, the size of the tumor. And they suggested us, better you can continue with the same hospital where you used to treat. So as we had no any other option, so we went back to Chennai, and they also informed us the same aspect, like the tumor was too big to be treated. So that was a very difficult time actually, but still, we decided to continue with the further chemo, and it didn't work that well actually as we expected. And finally, they told us there is a critical condition, maybe better you go for the surgery of this eye also. And for a second opinion, we decided to consult with a new doctor actually. At that time, God grace, we met Ma'am Feruza Ma'am actually in Bangalore. And maybe it was the very first time after 3 months, 3 years of treatment, this was the very first time we got a proper information about this disease. Till the time it was we were informed, okay, the baby is good condition or in the bad condition. Only 2 words they used to say actually. But ma'am informed us about the real condition with all the graph and all the pictures. She just explained it in a very proper way. And it was, and she really suggested the condition of the eyes. And by the time, we were thinking about go for the chemo, and one day we will be all right. But the real seriousness of the tumor was explained by the doctor. So we decided to go for the surgery because it was our priority. The priority was to save his life because we wanted to see him always, and we can always see him. We can see for him, in fact, actually, that is what I was talking about. So we decided to go for the surgery, and now he's fine. He's at home. He's doing well, actually. And the thing is that what I just wanted to tell every parent, never make any kind of delay, because sometimes due to lack of awareness about this particular disease, sometimes we get late for starting the treatment. And maybe this section will definitely encourage many people to at least go for a proper checking on the eye of children, at least after their few months of their birth actually. And this is the first area when the treatment was delayed actually. So the time to recognize what was the problem. Then the second aspect I wanted to tell everyone, maybe the doctors would suggest you chemotherapy. That is the possible best treatment available for the disease, as the doctor was talking about earlier. So I really suggest the doctors would not tell you anything wrong. Means they just wanted to save the life of your kid at least. So I really suggest every parent to follow the leads of doctors by giving more priority. And the last and final aspect I just wanted to remind all the parents who are listening to me, better you always consult with the doctor who are specialized in this area. So rather than going to a normal doctor or a kind of, we say that they see medicine like kind of traditional things and all, better you consult with the doctors who have some well-versed knowledge about the particular disease. Then definitely they will be able to give us proper guidance. And in case of treatment, sometimes, as we all know that, like, when we go through particularly the kind of diseases like cancer, there can be a lot of money required. So in case of any financial trouble, better you discuss your problems with the doctor concerned, and they will be definitely suggesting you some ways how to fund for the treatment actually. And this is also because of lack of money. I really suggest please don't abandon the treatment or follow-ups actually. And this is all I just wanted to talk today. And I always sincerely wish may God always give a lot of blessings to all these doctors to help the kids and bring them back to the world of vision. Thank you. Thanks a lot for listening.
Thank you so much, Mr. Shireen. And from our side, the prayer that we have is all these children, they should be always blessed. And in some way or the other, these kids are always actually blessed. Since, they have gone through some difficulties, the nature has been very, very good to them. They are excellent in some other field. And, all these kids, they really grow up to be super smart individuals. So God bless all these tiny little souls to do excellent and well in their life in future. And well, thank you, Mr. Shireen, for highlighting the facts, what the parents should be, aware of. And I'm sure, your pathway and your journey was not easy, but still you guys really held on to it with lots of courage. Yeah. So God bless. Yeah. So with that, we have a patient of us, Manikya here. Well, Manikya's journey was also not too easy. So Mom, are you there? Manikya is there? Hello? Yes. Hi. Yes. So we have a parent, and we also have Manikya here, who has been a champion all throughout. He's a survivor, and he has done excellent in his life. And he is, Mom, you want to tell what all prizes he has won so far? Mom? Mama, what all prizes has he won so far?
Sorry, doctor.
What all prizes he has won so far?
This year, like a achiever winner in Spell Bee.
Okay.
And studying topmost.
The best performer in school?
Yeah.
You're right. He's the master of ceremony of all the social activities in the school.
Doctor.
Yes, and he's a singer.
Singer अभी थोड़ा कम कर रहा है.
अच्छा ठीक है. Yeah. So this is how
अभी थोड़ा कम हो रहा है.
Yeah, so I just wanted to say that, all these kids do really well in their life, despite going through so much of difficulties. In fact, parents go through a lot of difficulties. Manikya, do you want to talk to us something? Do you want to tell us something?
Doctors are not treating like doctors. They are like friends.
They're like friends, really?
Really?
And you're happy about it?
Yes.
Okay. Are you scared of going and meeting a doctor?
No.
No. All right. So how is your eyes now? Everything is fine?
Yes. Fine.
Okay. Okay. And how often do you go and meet your doctor?
What?
How often do you go and meet your doctor? Do you meet your doctor always in a year? How many times?
2 times.
2 times. All right. Do you want to say something else to everyone here? Because so many people are listening to you. No? All right. Mom, do you want to say something, a message from you for the parents?
मैसेज नहीं डॉक्टर, सिर्फ इतना बताना चाहती हूँ, अगर डॉक्टर्स कभी फॉलोअप के लिए बताएं, इतने डेट पे आओ करके बोले, तो प्लीज सबको मैं इतना ही बोलूंगी कि प्लीज हर बार फॉलोअप के लिए जाइए, डिले मत कीजिए, यही बताना चाहती हूँ डॉक्टर।
Okay.
क्योंकि अगर प्रॉब्लम तो हमको ही होगा ना, अगर डॉक्टर्स का फॉलोअप पे हम नहीं गए, तो वही बताना चाहती हूँ।
Okay. Okay. Thank you so much. Thanks. Manikya,
ओके
thank you
डॉक्टर,
for
डॉक्टर वन
joining.
क्वेश्चन,
हाँ,
मैक्युलर क्या होता है?
macula.
हाँ,
Acha. So macula is the area in the eye which is next to the optic nerve, which is kind of a vision center in the eye. So
ओके
macula is where you get a very clear vision. So the nerve has to be good, and the macula. In the macula, we have a center called fovea. Fovea is more important. Macula is an area. In the center
ओके
of the area of macula, we have a fovea. So I know why you are asking that, because by birth, some children, most of the children by birth who have retinoblastoma, the tumor actually grows in the center. It's usually a macular tumor. Macula is an area, and in center of it is a portion called fovea, which is very, very important for the vision. So yeah, so if that area is clear, only then the vision will be good in the eye. But if a tumor is covering that area, then probably we will not be able to save the vision in the eye.
सो अगर उस पे लगा तो ट्रीटमेंट का कोई ऑप्शन ही नहीं है?
मामा, ट्रीटमेंट का ऑप्शन तो है, हम ट्यूमर को श्रिंक कर सकते हैं. कभी कभी मैक्युलर ट्यूमर है भी, ऐसे श्रिंक होता है कि फोविया शायद क्लियर हो जाए. सो अगर मैक्युलर ट्यूमर है भी, with chemotherapy, if it shrinks and it moves away from the fovea, still sometimes we can get vision in that eye. It's not like the tumor will completely melt away. वो तो कभी नहीं होता. हम shrink करते हैं ट्यूमर को, shrink करके we regress it and then make sure that it doesn't grow bigger. Yeah, treatment is the same, whether it is in the macula, whether it is in the other part of the eye, treatment is definitely the same. लेकिन आउटकम थोड़ा विशन के हिसाब से चेंज होगा. या ऑल राइट. रोलिका
तन्मय
जी,
सर को हम इच्छा फाउंडेशन को थैंक यू बोलना चाहते हैं, जो हेल्प कर रहे हैं ट्रीटमेंट एंड एजुकेशन के लिए.
ओके, या थैंक यू सो मच. थैंक्स फॉर कमिंग. एंड डॉक्टर रोलिका, do you have a concluding remark for today?
Yes, I have one concluding remark for all the parents. Actually, you should know this, that the child is extremely blessed to have you as parents. This is something that we often always forget, but the children are blessed to have been born with you, that they are blessed that you are taking care of them. So consider yourself very lucky. And thank you, Feroz ma'am, for conducting this wonderfully well knit webinar, where you have made sure that you have all the elements put together. You have made sure that there is a pediatric oncologist, there's a pediatrician, there's an oncologist, there's a histopathologist, there's a parent, there is a child, and you've covered all the elements, ma'am. Thanks a lot for your
Thank you so much, Dr. Rolika, for that positive note at the end of it. And well, we always look for the silver lining and positiveness in any disease that we come across. And for me as a doctor, for you as a doctor, for a parent, for a child, I think we should always look at the positive aspect of it and, start the journey with all faith and hope. And well, things will fall in place. So thank you once again, everyone, the audience, everyone who has been listening to us. I hope in some way this has been a useful webinar and some positive message has come out of it. And in fact, that was our aim and goal. Once again, thank to all the speakers, Dr. Sunil, Dr. Vasudha, Dr. Kaustubh, Dr. Rolika, Mr. Tanmay, Mr. Sherin, and my little Manike Shetty and mother, who has again joined us over here. And big thanks to Entode once again for helping us in this social initiative. So may I request Entode to have a video for us played regarding your organization. Congratulations, entered on the century, 100 years. Your contribution has been very, very valuable as far as the pharmaceuticals is concerned. And once again, we appreciate your social initiatives in every form, and thanks for your help always. All right, so with this, we come to the end of this webinar, and good night to everyone.
Good night to you, ma'am. Thank
Good
you.
night. Yeah.